Okay, is the screen visible, Raghu?
Yeah, it's visible.
Okay. All right. Sorry. Okay, good evening, everyone. Thanks again for joining us. We have around, I think, 12 cases today. And we are also happy to have Dr. Manka, Dr. Baltazar, and Dr. Sangeeta joining in as our guest expert panelists. We'll start off with our first case. The first case is from Dr. Prerna. So, Dr. Prerna, please go ahead.
Sorry, just pardon my voice. So this girl actually previously developmentally normal, but since the last 2 years, this 8-year-old girl presented with progressive worsening of gait. And since the last 3 months, she started having abnormal eye movement. She also had a background of poor memory and school performance, and there was history of second-degree consanguinity in the parents. So before this, she was evaluated by adult neurologist, and they had given the diagnosis of either ataxia with oculomotor apraxia or ataxia telangiectasia. And they had done AFP and immunoglobulin profile outside, and that was normal. There was a very strong history of mother's sister having a similar presentation of ataxia at around 10 years of age, and progressively that worsened and she became non-ambulant by age 15. On examination, she had cerebellar signs positive with oculomotor apraxia. Her deep tendon reflexes were present. There was no evidence of any neuropathy, and she was so there was no other systemic findings other than I felt that there were telangiectasia, conjunctival telangiectasia.
Are these the ones? I wasn't able to appreciate.
Yeah. No, actually, I think this was just a photo, phone photo, but they appear quite reticular and lacy in her eyes that you wouldn't normally see in a normal cornea, so conjunctiva. So I thought that probably this could be. I'm slightly doubtful whether they're actually telangiectasias or not.
Okay.
But she doesn't have any skin telangiectasia.
Okay. Okay. All right.
So sequential scans were done. One was done a year back, and then I repeated the scan. So these are just copies from the phone because they didn't have a CD.
Okay, that's all right. So we'll go ahead with the images. So this is the latest scan from November 3rd. And you can appreciate on the axial images on top, there is a cerebellar atrophy, predominantly in the vermis, the superior vermis, and the inferior cerebellar hemispheres. The brainstem on the sagittal sections demonstrate relatively normal volume. Corpus callosum also demonstrates normal size. No supratentorial atrophy, no structural malformations on the images. And the central regions of the brain also demonstrate normal appearance. No leukodystrophy or any such abnormal white matter changes. This is the previous scan, almost more than a year before. And again, you can appreciate that the cerebellar atrophy changes are pretty similar, predominantly involving the superior lobe of the vermis and the inferior cerebellar hemispheres. Again, supratentorially, the corpus callosum demonstrates normal volume. Brainstem again has a similar volume. These are the two scans in comparison. On top is the scan in 2021, and the bottom is from 2022. And you can see that at least to my eyes, the cerebellar changes have not significantly progressed. The vermis and the inferior cerebellar hemispheres predominantly demonstrate volume reduction changes. And on the sagittal image also, there is no significant interval change or progression in terms of the scans. So based on the imaging findings alone, this is a paper from Dr. Baltazar, who is with us. The child has isolated cerebellar atrophy. Ataxia telangiectasia is one of the common differentials for pure or isolated cerebellar atrophy. This is just a companion case which we had over here, and you can appreciate the telangiectasias more prominently over here. This is the child's ataxic gait, and over a 6-year period of time, the child initially had a normal cerebellar volume, which had progressed to the diffuse cerebellar atrophy. So ataxia telangiectasia, if you consider that diagnosis given the conjunctival findings, the primary abnormality is cerebellar atrophy with predominant changes in the superior vermis, which later becomes diffuse. They usually are associated with elevated serum alpha protein levels and low immunoglobulins, which are not present in our child. These are just again papers, publications with approach to cerebellar atrophy. Again, ataxia telangiectasia stands under the isolated cerebellar atrophy, and they can also have extrapyramidal movement disorders and oculomotor apraxia. But the serum alpha protein levels in this study, 6 patients, I think, sorry, 3 patients had normal serum alpha protein levels, and the children also can have normal MRIs, that is no reduction in the cerebellar volume. So this does not completely exclude the diagnosis, but yeah, it is common being common. Alpha protein levels are elevated and immunoglobulins are low, and there is usually some degree of volume loss in the cerebellum. At this point, these are our possibilities, and I'll open the case for the discussion.
One odd point is this: the pattern of inheritance here is autosomal dominant. No, the maternal aunt is affected and the child is affected, but ataxia telangiectasia is an autosomal recessive disorder.
Recessive. Yeah.
So how can we explain that?
We don't know the exact diagnosis in that aunt, do we?
No, sir. We don't know the diagnosis, but the presentation was very similar. So I thought that maybe it's a significant history.
Maybe there was a lot of consanguinity in between these families, so it could be still. Can I just make a comment, support what Nihaal said? I mean, the clinical presentation is not specific, not diagnostic. Rarely AFP can be normal and immunoglobulins, and MRI is not specific. So finally, you depend on a genetic confirmation, or whether you find AT or R1 or anything else.
So my question to the experts here was that should I be repeating the AFP and the immunoglobulins at some point again to see whether if it rises after a few years, what would be the interval for scanning? Do I need to repeat the scans? So how should I proceed with this case? Obviously symptomatic treatment, but in terms of imaging and investigations other than genetic testing, because if I'm looking for ataxia telangiectasia and or spinocerebellar ataxias, the panel would be completely different as compared to a clinical exome.
Can I add, in my opinion, number one to do is genetics. Repeat immunoglobulins does not really help. It can be normal for a prolonged time. Repeat MR without any new elements is not really helpful. If you think this could be AT just in terms of precaution, AT is a DNA repair disorder, and it is advised that you use X-rays, I mean ionizing radiation, avoid if ever possible. AT has a high prevalence of malignancies, in particular leukemia, lymphoma. Yeah, you depend on genetics, I think.
The other biochemical markers you can look at, or you can look at the cholesterol and albumin levels. Like cholesterol is elevated and albumin is low. Ataxia with oculomotor apraxia type 1 can be a possibility. That's one other biochemical marker which you can have, which you can look at.
But would they have so many changes, like the Vermeer changes are very classical for AT, aren't they, as compared to AOA?
Dr. Nihaal, do you observe this much of cerebellar atrophy in patients with ataxia with oculomotor ataxia type 1, apraxia type 1 and type 2?
Yeah. In the panel above, you can see it's the third choice over there with pure cerebellar atrophy. So it can be seen, but the superior vermis involvement and the cerebellar hemisphere involvement is more typical of ataxia, but I would say it's variable.
Sure.
The only other question was, do they present earlier, the ataxia telangiectasias, in terms of ataxia more towards the infancy or early childhood rather than 8 years or 6 years?
I think they usually start somewhere around 3 to 4 years of age, probably, and she's a little late. But I think probably they did not notice her symptoms Because they're from quite remote areas, so I don't know. Maybe that would be. She could have had minor incoordination and imbalance that progressively worsened.
Okay.
AOA1 and 2 have, I think, quite consistently a peripheral neuropathy. Maybe clinically, but at least in terms of electrophysiological studies.
Okay, thank you.
Okay.
Her deep tendon reflexes were normal. And she did not report any paresthesias or any other signs for peripheral neuropathy.
All right. Are we testing for a whole exome, or what is the next step?
Yes, I'll be sending them for whole exome sequencing.
Okay. All right.
Okay,
Hopefully you can update us with an answer.
Yes, I'll update once I get the results. Thank you.
Thanks. Thank you. Next three cases from Dr. Vivek. Dr. Vivek, if you're there.
Okay, so this is a 6-year-old boy who always had neurodevelopmental issues. He had global delay, just some recognition of his family, completely dependent on family for all activities of daily living. He's autistic and subtle dysmorphism and very fair complexion. And first year he was quite hypotonic, but now he was able to walk, but with some imbalance. That's his story for last 6 years prior to this event, which happened 9 months back. And he was being evaluated for global delay, autism, hypotonia, dysmorphism. He has been to Gangaram, CMC Vellore, and genetics has been done. And that showed that he had VC, they were not sure. They had a compound heterozygous mutation for VC syndrome, but he was not fitting exactly into it because that condition often has sensorineural hearing impairment, which he doesn't have. He doesn't have cataracts, he doesn't have cardiomyopathy, but he does have some features. So we were not sure what underlying genetic disorder he has, but he does have a VC syndrome gene compound heterozygous mutation. So that was his background. So 9 months back, he had a fall just from 2 feet height. And then soon after, he developed left-sided hemiparesis, which recovered within few days. He was back to his baseline function. CT at that time had shown a right caudate hematoma, and there was already gliosis present on both right and left side, and normal CT angio images I just sent today. I'm not sure, Nihaal, were you able to accommodate?
No, sorry, I was not.
Father came today evening, so I sent them today. So at that time, CT had shown a right caudate hematoma, and he had gliosis in both caudates. So he must have had on the left side some event before, but they couldn't remember. So he recovered within few days to his baseline functioning. And for the next 8-9 months, he was fine. And then because of his imbalance, he just again had a fall. And when he had a fall this time, he actually again developed left-sided hemiparesis like last time. And he has marked significant left arm dystonia and left leg dyskinesia. So left-sided. Now, when we did a CT this time, he actually had the same side left. So this time the acute lesion was on the same side as his movement disorder. So this is a CT just done 10 days back. So the previous CTs and MRI 9 months back, we couldn't get in for this presentation. So this is this time, just 15 days back when he had the second event. And the main issue has been that he has become quadriparetic and he continues to have a significant movement disorder on the left side, left arm dystonia, left leg dyskinesia. And so he's more on a, NG feed, physio, medication for his dystonia and movement disorder. But I just wanted to discuss his CTs, and I think we had an MRI as well.
Yeah.
So as so he does have basal ganglia calcification bilaterally, and at least it was there in the CT from 9 months back. I'm not sure if we will be able, but this one also shows it. And he also has both-sided gliosis. The thing I couldn't explain was the same side movement disorder as the insult acute this time. because this time acute insult is on the left side, and same side he has the movement disorder. And just any from the forum experience of VC syndrome, if VC is associated with mineralizing angiopathy associated stroke, or stroke is associated with in this kind of, because we know post-trauma stroke is there, but just with his background, I don't know whether there is an association.
All right. Yes, sorry. It's actually VC syndrome. There is no N. That's a typo, and this is from November 4th, not April. So the CT demonstrates bilateral gliosis with reduction in the basal ganglia and punctate calcifications on both sides. Coming to the MR, you can appreciate the hemosiderin lining of the cystic gliotic cavities on the bilateral basal ganglia. And in the diffusion weighted diffusion changes, you can appreciate the more recent abnormality involving the left caudate, putamen, and also the lateral corticospinal orbital tract extending up to the midbrain. The chronic changes are there on both sides. There is reduction in the supratentorial brain volume. The gradient or SWS sequences demonstrate the calcifications more confluent on the right basal ganglia. The corpus callosum is foreshortened and hypoplastic. Whether this is a normal finding or not, it is slightly small for only a child with only stroke. That was slightly abnormal over there.
Sorry, VC does have corpus callosal agenesis. So dysgenesis is there or not, but it does have agenesis, dysgenesis.
I mean, it is in form of the morphology, it is complete, but it is foreshortened and thinned out. Post contrast, again, you have some leptomeningeal enhancement over there, but nothing very significant or nothing which adds to the diagnosis, possibly some vasculitis. So the imaging diagnosis is of a mineralizing angiopathy, and Dr. Vivek himself is on the paper which was recently published with 48 cases. These are the salient features I think most of you would be knowing in the audience. So I'll just open the case for the panelists to discuss upon the clinical presentation and if they have any similar experience with their children with mineralizing angiopathy or VC syndrome.
I don't have a personal experience with VC syndrome, but as was just commented in the chat, if you read about VC syndrome, which is, by the way, a model of autophagy disorders, corpus callosum dysgenesis is on top of the list. It's almost consistent, and otherwise it's a multi-system disorder with many potential organ involvements. Whether he has some kind of double trouble with these bilateral infarcts, I have to leave it open. But I think the genetic significance here for me is given.
And the explanation for same side acute insult and same side movement disorder, because the right side insult is old, and that so I couldn't explain the movement disorder of the left side where he has had an acute insult. It's just restricted to the left side.
If this patient would have, excuse me, there are a few conditions, and including a few kind of normal people, they have an axonal navigation disorder and the corticospinal tract, they just don't cross. You could postulate whether this patient has axonal guidance disorder.
The other reason could be because right side is completely hemiparetic. So maybe the right side is not even able to move to cause a movement disorder. And on the right caudate, there is a hemosiderin deposit. Maybe when he fell, he had hemorrhage on both sides. So right side also had some acute on chronic insult, which is causing the left-sided movement disorder. Is there an acute on chronic insult on the right side?
Nothing on the diffusion there. They're only on the left.
Right.
I think I discussed this with on the fellows who asked our consultants. If Geeta is there, I think there are similar cases. Geeta or Dr. Lokesh?
Yes, sir. Actually, we have similar cases, and any silent infarcts going on can behave like this, sir. Like.
So silent infarct when something happens, can behave like an acute problem,
Yes,
right?
sir. Yes, sir.
And they had suggested functional imaging to, I think 1 or 2 cases got functional imaging and they found out the cause that was on the contractile side. Is that right, Geeta?
Yes, sir.
Functional imaging for what? Functional imaging?
To look at the other side, how is the
So you mean to say
function?
DTI or functional? DTI you mean to say, or functional?
Functional, sir.
Functional.
Not DTI, sir.
Okay.
Functional MRI.
Functional MRI. Okay.
There's a question where if it is sulfate oxide deficiency from Jordan saying classification slightly atypical. I think sulfate oxide predominantly involves the caudate nuclei rather than the putamen, if I'm not mistaken.
Late onset sulfate oxidase variants usually have typical involvement of globus pallidus.
But do they have recurrent strokes?
They present with stroke mimics.
His homocysteine, they had low as well, isn't it? His was normal, 10. It was not low nor high.
Okay. Would the SOD be picked up on the genetics?
And it will be picked up on genetics.
Yeah.
If somebody gives the possibility, I'm not sure if not given then. But corpus callosal dysgenesis, is that a part of SOD? I don't know.
Not typically, I mean, not commonly at least.
Are there any radiological markers for VZ syndrome other than this stroke, pontine hyperplasia, undervascularization of Sylvian fissures, delayed myelination?
No, not really. They're only generalized atrophic changes and.
And what could be the possible mechanism for stroke in these children?
So I couldn't find any reports of VC syndrome patients having more chances of stroke. So it's not been reported.
Yeah, even I have not been able to find any, at least the reviews which have not.
So I wonder if that calcification which is contributing, and VC patients also might have mineralizing angiopathy.
So the main findings are absent corpus callosum. Yeah, that's and microcephaly.
And
in terms of,
and this child has a large head actually. And the midbrain has a lesion, left midbrain. So there's a posterior circulation involvement as well. Is that right?
No, that's just the prevalent degeneration of the stroke of the basal ganglia. So that's along the cortical spinal tracts there.
Okay.
So it's acute valerian degeneration.
Right. Okay.
Vivek, Dr. Mahesh here. Was there history of any PROM in this child? PROM or any neonatal admission?
Sorry?
In history of PROM?
Premature rupture of membrane?
Yeah.
I didn't ask that. For the mineralizing angiopathy?
Yeah, because this I see many cases with PROM who have both thin corpus callosum and mineralizing angiopathy, and they do come with bilateral infarcts.
Right.
And I have one child who's got a movement disorder which is going on for almost last 5 to 8 years now.
Right.
So despite a good number of drugs, I even did a genetics for the child, genetics was negative. So mineralizing angiopathy can come with thin corpus callosum and even with bilateral infarcts.
Right. So I'll ask them
most
next time.
Yeah, either NH admission or a PROM issue can be asked for. Okay.
Yeah.
Okay.
Okay. Thank you. We'll move on to our next case.
So this child hasn't been investigated much. So I had sort of cheated. I thought I'll have a differential from the meeting here and then I'll investigate. So because I didn't had much investigations before. So he's a 14-year-old boy, no problems prior to 3 years back. And then he had frequent left focal seizures, which are still ongoing, and family had taken medications on and off, which had not helped. And there has been mild cognitive regression, but it has been the motor regression which has been more predominant. He's got a spastic ataxic syndrome. So he's spastic in his legs, hyperreflexia, clonus, with imbalance. So that's his video. He's quite sharp still, but family feels he's academically deteriorated. And see the short, slightly broad-based gait, and His Gowers was negative. I initially thought he had a sort of a Trendelenburg gait as well. And his left side is more affected than the right. So it's happened in the last few years. Only before that, till 11, he was completely normal. They showed me the video as well, and he was good.
Any visual problems? Any hearing
No.
problems?
No hearing or visual problems. Like they haven't, so he hasn't had any, so I haven't asked for any hearing problems, sorry. But like it didn't look like, as I remember, that he had any, but I haven't asked for it, but there's no visual problems.
For the epilepsy since 3 years, since
For
when is
last
epilepsy?
For
Okay,
last
last
3
years.
years. Last 3 years. Initially, when he came in, I thought, is he got Rasmussen's left side? Not that before I examined him, because of so frequent left focal seizures, left hemi. But obviously, when he walks, then it didn't. So I was struggling for somebody mentioned clinical differentials. So yes, Rasmussen was there, and I didn't think of Paul G. That I haven't thought of at that time.
Okay. We'll move on to the images. So this is, how recent are these, Dr. A?
Just 15 days.
Okay. So there is some reduction in the supratentorial volume, possibly in the vermis over there, but significantly cerebral atrophy over there. And you have some areas of confluent hyperintensities in the deep and superficial white matter on both sides. The periventricular regions are relatively spared, corpus callosum is spared, the central regions of the brain are relatively spared in terms of the signal abnormalities. There is uniform loss of the cerebral brain volume, no asymmetry, which is typically seen in Rasmussen encephalitis. Usually the one side of the brain is usually affected more severe than the other side. So yeah, just white matter changes in the deep and superficial and some areas of subcortical white matter. Cerebral reduction in the volume. Diffusion, no significant area restricted diffusion. On the ADC, they show facilitated diffusion. The corpus callosum is reduced in volume, and there is some reduction in the size of the vermis. So I could not think of any radiological differentials. I checked with our consultants if it fits spastic paraplegia or not, the HSP variants, but they were not sure. So at least imaging-wise, I wasn't able to come to a pinpoint diagnosis. So I'll open the case for the panelists to discuss upon.
So there's no ichthyosis. There's no ichthyosis. And he has hyperreflexia, so SMA will be unlikely.
I don't have a diagnosis, but I'm impressed by bilateral, slightly asymmetric white matter changes. But for me, this does not look like a primary white matter disorder. It's rather a primary gray matter disorder, and these white matter changes are kind of like a Wallerian axonal change. You probably would go to genetic exome.
And EEG shows slowing, diffuse slowing for his age, right more than left. That's it. Okay, no epileptiform discharge. So Paul G is a good possibility, then maybe think of that.
At least imaging wise, some typical findings are not there for Paul G, but yeah.
And homocysteine also I will do, because light matter changes.
Yeah. But I think it's, as Dr. Bolta said, it's predominantly a gray matter disorder.
And there's no myoclonus. There's no myoclonus, no history of measles, because you always think of SSP when somebody comes like this.
Yeah. They usually tend to be slightly asymmetrical on the imaging, but I mean, common being common. There's a comment on HIV. Was there any drugs given, Dr. Vivek, at the before 3 years or anything?
So no history of blood transfusions.
Any inciting event which has caused, first up till 11 years is normal, and then
nothing, just started with seizures, and then so present medication, he was actually not treated for years, and just a month back he was started levetiracetam. I've started him on oxcarbamazepine. not given valproate.
Okay, there are suggestion of NCL. Yeah, cerebellum would be slightly more commonly involved, but
Yeah, cerebellum is more involved, right? NCL.
yeah, and they're usually periventricular confluent areas, some darkening of the anterior to thalami, subinsular white matter changes. I mean, the typical NCL changes.
And
But I'm not aware of the PME phenotype. What PME stands for.
The NCL was also in my mind for a time being. This was my question about the visual problem. If you would consider this kind of a juvenile form in the broad sense, you would expect some retinal involvement, definitely.
I'll get his ophthalmology done formally and see. So it's not been done.
Friedreich's ataxia does not lead to white matter changes.
MTHFR deficiency is a possibility, and can't it be a juvenile MLD?
Yeah, juvenile MLD is a possibility, and for MTHFR, yes, I was doing homocysteine. Juvenile MLD, what about Nihaal? Corpus callosum? Does it?
Yeah, it's spared.
Spared.
Usually the periventricular regions also are relatively spared.
But that's a good possibility because
Yeah.
Juvenile onset can present like this.
But in
But
ML, I
again,
mean,
juvenile
the
onset
MLD,
is more of a white matter, right? So seizures,
Yeah.
seizures are predominant finding, starts with seizures, focal seizures then.
The question of Sjögren Larsen was raised. I've seen two patients. They have impressive skin changes.
Yeah, no ichthyosis, no skin changes. So maybe MTFHR, Paul G, and
Yeah.
juvenile metachromatic leukodystrophy. I'll update.
Okay, all right. Thank you. Yeah, okay, you can proceed.
So this is a 9-year-old girl who initially had swelling on her right tibia a few months back with prolonged fever. And at the time she had a lytic lesion in her tibia and it was treated as osteomyelitis. Curettage was done. And on the debridement, Staph aureus had grown. So she was treated as Staph aureus osteomyelitis. But then so it started with fever. The fever did not improve in spite of this intervention and continued, and she developed bicytopenia, low hemoglobin of 5 and platelets very low. And she also once had a left focal seizure. So with this history of bicytopenia, we did her bone marrow, which revealed histiocytes, and ferritin was 800, just mildly raised, and there was no history of DI. So with this lytic lesion, bicytopenia, histiocytes, we thought there's no hepatosplenomegaly, no organomegaly, and triglycerides were normal, and LDH was normal. So we thought, is this Langerhans cell histiocytosis or HLH because of this? And then we did the MRI, and there are some X-rays also of the lytic lesion.
So I think these are images from the mobile phone, so they are slightly artifactual. The skull X-ray, the AP view, at least I cannot see any lytic lesions over there. The tibia, you can appreciate a slightly ill-defined lesion. The cortex, or the outer margin of the cortex, is also involved. It is predominantly involving the shaft or the diaphysis. On the chest X-ray AP view, I cannot appreciate any lytic abnormalities, no flattening of the vertebrae, which are commonly seen in LCH. The knee joint, there's a slightly lytic sclerotic rim over there in the metaepiphyseal region. But other than that, nothing. And I think these hypolucent areas are likely bowel shadows. I'm not sure of this the left lytic lesion, or if it's a lytic lesion or a bowel shadow, given the image quality. So the primary lesion is of the tibia, and we'll move on to the MR before we come to the musculoskeletal discussion. The MR, there
There's
is
no,
again.
there's no skin
sorry.
discharge, skin lesion or ear discharge, just to complete the history. Sorry.
Yeah.
Could you please specify the location of the tibial swelling? Was it in the area of the lytic lesion or was it the whole tibia area?
So it was in the area of the upper tibia, in the region of the lytic, in the lytic lesion. But the problem is this X-ray was done in a hospital after a month of debridement. So we don't know this is because of the debridement or the lytic lesion was there. This lesion is because of debridement. We
So
don't know.
this lesion could be secondary to that infection, to this osteomyelitis?
True, this could be.
Yeah. So the cortex which is not distinct or incomplete is likely due to debridement. Is that right, Dr. Ravi? I mean,
Yeah.
we're not sure if this was intact or not previously.
Yeah, we were not sure because we don't have an X-ray, unfortunately, from before.
Okay, and no seizures, right, for the child?
One seizure, left focal, one seizure.
Okay, so there is a generalized volume loss of the brain, supra and infratemporal structures. There are patchy hyperintensities in the left globus pallidus putamen and also in the pulvinar thalamic nuclei or on the left side. Some reduction in the volume of the left half of the midbrain. The zoomed in flare images, you can appreciate the patchy, faint, subtle hyperintensities involving the globus pallidus and some areas of the putamen. Also, the pulvinar thalamic nuclei compared to the right side is slightly hyperintense. Punctate foci of blooming on the SWA sequences in the putamen and the left half of the midbrain over there. Mild reduction of the corpus callosum, that is in keeping with generalized reduction of the supratemporal brain volume. For LCH, pituitary gland is one of the common areas of involvement. Given this child does not have diabetes insipidus, the pituitary gland and stalk demonstrate normal appearance. This is the normal T1 hyperintensity on the non-contrast scan. The stalk measured around 1 millimeters, which is normal for that age group. So there is no infiltrative disorder or infiltrative lesion or infiltration of the pituitary stalk or the pituitary gland. It is demonstrating normal post-contrast enhancement. It is slightly partially demonstrating empty cellular type appearance over there of the anterior lobe, but nothing suggestive of an LCH type lesion. I wasn't aware of the X-ray being a post-debridement X-ray, but just for the discussion, the LCH demonstrates lytic lesions in the diaphyses of the bones, and they can be ill-defined or well-defined, usually present between 0 to 10 years. These are the various manifestations of LCH. The long bones usually have diaphyseal and metaphyseal involvement. And common brain imaging findings are the infiltration or the thickening of the pituitary stalk. There can be some focal white matter lesions. It is not specified what they usually present. The skull can present with lytic lesions. You have this vertebral planar type appearance of the vertebrae, lytic lesions of the ribs, ill-defined lesions of the metaphysis and diaphysis, and they can also breach the cortex. So I was under the impression that it has probably breached the cortex, but wasn't aware of the post-debridement scan. And HLH, at least the imaging findings are not typical of an HLH. They usually have multifocal or concurrent abnormalities involving the white matter and the deep gray matter. Cerebellum is commonly involved and have this typical post-contrast enhancement pattern. Optic neuritis is a feature of HLH. So at least on the imaging wise, I'm not confident enough to call it HLH. And LCH also, at least the brain imaging is not typical of an LCH. So I'll open the case now for the panelists to give their opinion. No neurocutaneous markers, no, Dr. Veer?
So no skin lesion, no organomegaly, and no ear discharge.
And no stroke. Stroke.
No stroke. And sorry, it was not left focal, my right focal seizures. So not left.
My tendency would be to wait and see. I'm a rather conservative person. I'm not convinced of that Langerhans cell hypothesis.
It's difficult to explain the persistent thrombocytopenia and anemia in a 9-year-old girl who was so well before with persistent fever. So a girl who had fever with tibial swelling, and in spite of debridement and treatment with antibiotics, fever continues and she has bicytopenia. And then our bone marrow was done, which shows histiocytes. Because of these bicytopenia, bone marrow was done. And so that's why the differential of LCH.
Yeah. Just to add, I think the imaging doesn't help much over here. At least the typical handles are not present. I would base it on the clinical presentation.
Retrovirus was normal. She had a retrovirus done. B and T cell subsets have not been done. So BT and so we've not done the TBNK. So
Immunoglobulin
that
profile,
can,
yeah.
no, but that will that explain the thrombocytopenia and anemia? You know, immunodeficiency is causing an histiocytes.
Reason for seizure.
Unable to explain by the basal ganglion thalamic lesion, though it's on the left and she had right focal seizure. So still not able to explain. Parents are also asking me, I don't have answer.
Yeah, but that I think that would be a post-ictal change, even if it was on the
Yeah.
contractile side.
Yeah,
But what is the cause of the seizure? What,
I don't know. Sugar was normal.
And only one episode of seizure. So
Yeah, one, but it was a focal seizure.
So audible interleukin-2 receptors were done.
So you mean to say CD25, soluble CD25 or
SAL2R for HLH marker.
or CD25 soluble? That's not been done. So that actually has, because you transferred the child just few days back to the hematologist period. So I think they are doing that workup. So I still have to come back. I will talk to them and next time let you know. So they are doing the two markers, CD25 and IL-2. So the hematologists are not in our hospital. So we have transferred somewhere else.
Dr. Anything to explain the atrophic change in the brain? Because I think they're giving only acute history, right? Or
yeah, so she
was
had
the
not
child
given
on?
no steroids.
Yeah, because the brain, I mean, the atrophy is slightly unusual for the just an acute presentation.
And she's not
Without
regressed.
steroids.
She's a smart girl. She's intelligent. So she isn't regressed clinically. And no steroids. So anemia, can anemia cause it? Few months.
Yeah, anemia can cause. B12s.
B12 has been done normal.
I'm just thinking sometimes the unilateral thalamic lesions can be seen in palsy, but the presentation is not typical of palsy.
And that dot in the midbrain, is that a calcification?
We didn't have the filtered phase imaging, so only the GRE was there. So it can be calcification of hemorrhage. Usually the filter phase will help to differentiate both the if it's a hemorrhage or calcification.
Okay.
I would bet on hemorrhage rather than calcification.
Some form of CNS vasculitis secondary because of
Possible.
the underlying illness.
Yeah.
Mention about asymmetry of the whole.
Yeah, there was asymmetry. So hence I asked you if it's only an acute presentation or there was any previous thing, but that is Wallerian degeneration over there. ANCA profile.
So she had ANA and she had MPO and PR3. These days we don't do ANCA. So it's been overtaken by MPO and PR3. So that was negative. CNS vasculitis, usually this profile will be negative anyhow. So, but yes, large vessel systemic, it was negative, ANA and myeloperoxidase and PR3 were negative.
No organomegaly, no lymphadenopathy.
No,
from
no,
Dr. Sangeet. Yeah.
no.
Okay, I think we're stuck with this case without a definite diagnosis. What is the next plan, Dr. Vivek? Anything?
So again, though soluble CD25 IL-2, and I'll ask them what happened after.
Okay, sure.
Aplastic anemia platelets are low. Usually they are not. I don't know. They have biocytopenia. But also one has to knit up that tibial swelling. So couldn't knit up everything.
If they got a staph aureus, then I think it could be osteomyelitis.
Yeah.
There. So we can attribute that to an infection.
Yeah.
Because there are no other typical lesions which are commonly seen in LCH or any malignant etiology. So if you get in with the culture or debridement of staph, then you can attribute that to an infection.
If she was a male, I would have sort of Viscott Eldridge if platelets are low, infections, but she's a female.
Any comments from the hematologist or
They think of LCH. That's what they have said, but they are send the soluble markers for HLH. So just 2 days back we sent her. So I'll let you know next time.
Okay. All right. Thank you.
Okay. Thank you.
Next two cases from Dr. Ramya. Ramya, you're there?
Yeah, I'm there. So this is a 4-month-old boy who came with a mild developmental delay with acute onset regression. So by the time he came to me, he was 4.5 months old. He had fever 10 days ago, following which he lost the acquired milestones as well. Previously, he was having some social smile and looking around. That was totally lost. His neck holding was also lost, and he was kind of not responding, most of the time sleeping, and then had feeding issues as well. And slowly, so over the course, for the next 1 month, he started having worsening encephalopathy, meaning initially he was crying, then sleeping. He had such phases, but later on he was just sleeping and not at all taking feed, and lost weight almost kilogram, and then was not so this was the history, but child's perinatal history is normal. He's second child of consanguineous couple. On examination, his head circumference was normal. He had spasticity in lower limbs greater than upper limb, and umbilical hernia, small one, was present. And otherwise, he was not fixing and following. Initially, when he came to me, he was having some fixation to light, but later on in the course, he lost his ability to fix as well. And TMS, urine GCMS was normal. Blood lactate and ammonia were also normal. Scans will follow.
Any seizures?
No seizures, no seizures.
Thanks.
Fundal findings, any hepatosplenomegaly?
Fundal we couldn't do, but he didn't have any hepatosplenomegaly.
So these are the scans, I think, at 3 months of age?
No, at the point when he had just fever and then started having irritability.
Okay. So the striking findings are in the posterior fossa. You can appreciate the dentate or the peridentate white matter demonstrates symmetrical abnormalities. The brainstem has these areas, the dorsal and ventral brainstem has T2 hyperintense changes. Coming on top, the posterior limb capsules should be dark at this point, are demonstrating hyperintense changes. So there is some delayed myelination over there. Given the age of the scan, I'm not able to appreciate if this is undermyelinated brain or abnormal white matter. Again, on the T1 weighted images, there are some hyperintensities in the region of the ventral thalami, the posterior limb capsules. Again, the dentate is slightly hyperintense on the T1. brainstem also cite hyperintensities with hypotense edematous changes or hypointense changes surrounding it. Diffusion weighted sequences could not appreciate any restricted area restricted diffusion, though the quality of image is slightly pixelated over there. Brainstem demonstrates these hypoplastic changes. The Burmese is also hypoplastic. Corpus callosum for a 2 to 2.5 month old child is relatively normal, maybe slightly thinned out there, but not very significant. CT was done, and on the CT scan, you can appreciate the punctate areas calcification along the bilateral central semioval or the deep white matter, and also involving the pyramidal tracts, that is the posterior limb of internal capsules. The dentate nuclei on the CT again slightly hyperdense than normal. You can appreciate the adjacent white matter is hypodense. So given the imaging findings, a possible diagnosis of Krabbe's disease was thought an infantile Krabbe's disease. The infantile Krabbe's disease usually have a posterior to anterior predominance, the involvement of the dentate and peridentate white matter. They have demyelinating leukodystrophy, difficult to attribute at this age, the child, but the infantile variants usually have these punctate calcifications along the pyramidal tract or the corticospinal tracts, which is also seen in our case. The other findings are more commonly seen in the later variants, that is the hypotense thalami or the T2 hypointense thalami on the MRI scans. So this was the primary differential which I thought of. These are the other leukodystrophies with the posterior to anterior gradient. And these are the various abnormalities which involve the dentate nuclei. Krabbe's disease, as you can see in our index case, has similar imaging findings. And other disorders, the supratendental findings usually do not match. Possibly the GAN and the MLD are common, I mean, most closely resemble it, but the posterior anterior predominance is not typically seen in them. It is usually more periventricular and diffuse. So Krabbe's is the primary differential you're thinking of. So Ramya,
Yeah, but genetics has given us one more variant. I spoke to the geneticist as well. She told Krabbe's is not there. And she has re-looked into it, and they came with the two variants, VUS. One is this one, and one more is TSOK, some gene which is not matching. So this gene is also the primary thing in this gene is the hyperkinetic movement disorder, which is not there in the child. They have given that these children can have some point regression, start off with developmental delays and such things, but it is not totally matching. And imaging doesn't match at all. So in this, what they have mentioned is imaging is mostly normal, and sometimes they can have GP hyperintensities. That's all. Yeah. So there was no correlation for this. That's why I wanted to know if there are further comments.
Enzyme analysis?
No, we couldn't do that.
Okay. Yeah, I'll open the case for the comments.
Well, the age, the history, the presentation, the acuteness, the irritability, the MR, many things speak in favor of Krabbe, as it was commented in the chat. But we have no evidence in the genetic investigation. Can you investigate the parents?
If we don't get anything on the index shell, how would parental testing help?
Good question.
Would it help or yeah?
I don't know. Maybe it will be add even to the confusion.
Sanger sequencing of this gene, I asked, but the parents were not very willing, so we couldn't do that. I mean, we got this report also recently only, so they might get it a little later.
You have done a whole exome sequencing or a clinical exome?
Yeah. A whole exome plus mito also we have done. Yeah, both we have done.
Can't it be a Lay-like syndrome?
That's what, ma'am. That's why I got mitochondrial also done. I've started cocktail as well, but there is no improvement at all, and he kept on deteriorating. So much so that he requires tube feeding.
Was there any peripheral neuropathy, nerve conduction?
That I couldn't do, but reflexes were not easily elicitable. Knee jerks were only 1+, but spasticity is there.
CSF analysis, was there any
No,
elevated
no.
lactate or protein?
CSF I couldn't do, but peripheral lactate is normal. Blood lactate is normal, I mean.
Would the enzyme analysis help? I mean,
Uh,
to look for therapy solutions.
yeah, it might. I don't know if there are some intronic variations or something like that. It might help. I'll try doing that.
Okay, probably
Yeah.
get back to us with this.
Yeah, sure. Okay.
Yeah.
Temperature changes the child didn't have.
Yeah, there's some question of microarray can pick up GLC deletion.
Okay.
Okay, thank you.
So this child is a girl child born to consanguineous couple. This child is 7.5 months old when the child came to us. Basically referred in view of cluster seizures over past 1.5 to 2 days. They were treating the seizures. Initially, they were at home. So this child had some 3 or 4 seizures. The parents couldn't identify. And by the time they came to us and already 2 loading doses were given. So the child had to be ventilated immediately in view of respiratory distress and encephalopathy. So after admission, at admission, child had 1 seizure, later didn't have any. And this child was having a mild developmental delay to start with. And 7.5 months, child is just smiling at mother. Neck folding is present. Child looks around, but there is no stranger anxiety. Then after that, and there is one previous IUD at 8 months of age for the mother, which that IUD child was a boy, and abortions at one abortion at 3 months of age. So this is the only living child. Then after ventilation, the child became deeply encephalopathic. And EEG was not at all contributory. It was just low amplitude. There were no seizures in EEG, and continued to have encephalopathy. So there was no preceding fever as well. CRP was slightly elevated, so we got a lumbar puncture and CSF analysis done, which was normal. I couldn't do PCRs because the parents were not affordable, but the LP picture was totally normal. And then the hair was little brownish in color. Apart from that, on examination, there was hepatomegaly. Initially, hepatomegaly was not there. The liver was just 2 to 3 centimeters palpable. But later on, somehow the hepatomegaly has increased. But on ultrasound scanning, the span was 8 centimeters only with mild splenomegaly. So I thought it could be both components of push down liver and then slight hepatomegaly. And metabolic investigations, TMS, urine GCMS, lactate, ammonia, everything was normal. The maximum lactate was 24 milligrams per deciliter. And unfortunately, this child had 1 episode of tube block, and CPR was required for this child. And later, child has not recovered at all. Finally, after 6-7 days, child passed away. I wanted to discuss the scan and any DDs that I could have thought of that time, or something which could be missed or something like that.
Scan at which age?
This admission only at 7.5 months.
Okay. So there's extensive supratentorial reduction, volume loss. Again, the plics are not completely myelinated for a 7-month-old child, but predominant gray matter atrophy involving the cortex. Brainstem also, there is some reduction in volume. Corpus callosum also demonstrates thinned out appearance. There's a small lipoma there, that is not significant for the case. Post contrast, there is no enhancement. The cerebellum in terms of volume is relatively normal in comparison to the supratentorial structures. So this we typically, I mean, I'm not completely sure of the diagnosis on the imaging, but these are differentials for extensive atrophy, B12 deficiency, NCL again, cerebellum is relatively normal. Biotinidase deficiency, if that's a possibility, trapopathies and mitochondrial disorders. At least on imaging, I could think of these other than the post seizure. I mean, was there only one episode of seizure? Or?
No, they were cluster seizures, but after
Okay.
admission, there were none.
Okay, so only, I don't think it
4 or
completely
5
explains.
seizures, yeah.
Okay.
And I thought of
Complete.
vitamin B12, so I have treated with that as well. Mitochondrial was also one of my thought. I have started supplements, but there was no coming back point. The child was totally encephalopathic, and upon which child also had to be given CPR. So had a downhill course.
Clinical possibilities, we can consider Alpers because of the hepatomegaly and poorly controlled seizures, peroxisomal disorders, CDG, congenital disorders of glycosylation. Was there any fat maldistribution or elevated liver enzymes, coagulopathy?
Liver coagulopathy was not the man, but liver enzymes were elevated to the tune of 2 times, 6 somewhere around 80 and 100.
Okay. Have you done any isoelectric focusing?
No, I didn't do that.
VLCFA, plasma VLCFA?
No, that also I couldn't do.
Was there any peripheral neuropathy?
No, he didn't have. In fact, he had clonus and very easily elicitable reflexes.
Okay.
Sorry. Biotinidase, if I remember it was normal only. But even then we have supplemented that. But cardiac involvement, no. Cardiac involvement was not there. Yeah, storage disorders were one of my consideration, but given the family background, I couldn't go for enzyme analysis. We have stored blood sample. We want to do genetics when the family comes back.
Eye abnormalities?
Eye abnormalities, we couldn't get a formal eye assessment done. That couldn't be done, but pupils were always sluggishly reacting. I mean, cataract was not there.
I think, are they thinking of the actocemia?
MOCO deficiency, molybdenum, we were, but MRA was not matching, is what I thought.
The imaging doesn't match.
Doesn't match, yeah. Except for atrophy, I mean, major handle otherwise is not there.
Yeah, we are in the burnt out state, unfortunately. I mean, at least on the imaging. So.
Hair Menkes. Menkes also was one of my thought, but then vascular, those findings were.
Yeah, they are not there.
They're not there. Yeah, those things were not there.
X-linked. This is a girl, isn't it?
Girl, yeah. Yeah.
Yeah.
There were many votes in favor of POLG in the chat. I add my vote again also to POLG.
POLG?
Yeah.
The liver enzyme elevations were not very high, and then lactates were normal consistently. And I don't know whether this much of atrophy, just atrophy, can explain POLG. Can be explained by POLG.
POLG-related seizures causing atrophy can be possible.
Seizures are not a major thing here. Only just for 2 days the child had that 4 or 5 episodes. Only for 5 minutes each. MPS.
Imaging doesn't match MPS.
MPS.
Was there, how was the head circumference?
Head circumference was around a little on the lower side, 40.
But MPS would not lead to such degree of atrophy in a baby. This is completely, I think, unusual, ruled out. I would not follow that track. Let's wait for the genetic result and give us a feedback.
Sure, sure, doctor. Sure. Thank you. Thank you all.
Thank you. Next case is from Pune, Sahil.
Yes, sir. So this child, sir, is a 9-year-old female child, born of 3rd degree consanguineous marriage. So she presented with in October 22 with acute febrile illness, and she was treated outside conservatively. And after which, what the mother noticed that there was a slight inattentiveness and cognitive decline in this child. Another episode in first week of November, this time she presented with acute febrile encephalopathy. And as a part of workup, COVID antibody was done, which was positive in this child. Other inflammatory biomarkers were done, which were normal, but LDH was raised. So was treated as a case of MISC. And as a case of acute febrile encephalopathy, she received acyclovir and MPS therapy also. So so the first MRI, which was done outside.
I don't have the first one as the second one, but the changes are pretty similar. So yeah. Do you want me to show the MR first?
Sir, the first MRI, the PDF, sir.
I couldn't put it up, but I'll show the second MR. This is after 6 days after the first MR. The changes are pretty similar to the first MR. So you have confluent white matter abnormalities in the bilateral cerebral hemispheres, also abnormal areas involving the brainstem. As you can see in the pons over there, the tracks along the medulla. On the T1, we didn't have a flare image, but on the T1 weighted images, again, the white matter confluent abnormalities demonstrate hypointense changes. Some areas of myelin sparing corresponding to T1 iso intensities over there. The central regions of the brain, that is the deep brain nuclei, are relatively, less affected in comparison to the white matter abnormalities. Again, brainstem demonstrates hypointense changes. There are areas of restricted diffusion, predominantly along the subcortical and deep white matter, and also in the brainstem. On the sagittal images, there is thinning of the corpus callosum, predominantly in the segments of the body. The inner blade of the corpus callosum is predominantly affected. The middle and the outer blade are relatively spared. Again, the brainstem extended abnormalities can be seen predominantly in the pons. A spectroscopy was done, and I could not appreciate any diagnostic peaks. There is no lactate, no succinate. So at least the MRS is not helpful at this point. So after that,
yes. So after that, she was referred here as there was no improvement in the consciousness after receiving 3 doses of MPS and cyclovir. And as soon as she came here, and we continued the same line of management. And after the 5th dose of cyclovir and MPS, her consciousness, her inattentiveness and cognitive function reversed back. The GCS improved. And so we did a CSF also in this child when she came first, and it was suggestive of, rest of the proteins and sugars were normal, but it was suggestive of HSV1 encephalitis. PCR was positive. So, so on examination, the head circumference is 3 to 50th centile. Her tone power reflexes are normal, but there is hypertrichosis in this child. So our doubt is due to is there HSV encephalitis versus succinate dehydrogenase deficiency versus SERF mutation in this child. So we have sent we have sent a whole exome plus mitochondrial genome in this child. Yes.
Yeah. At least the hypertrichosis differentials which I found on the internet for these mitochondrial disorders, commonly SERF1 mutation, but other mutations can demonstrate hypertrichosis. The other less commonly seen inborn areas of metabolism or genetic disorders with hypertrichosis are listed over here. The question was, is it a mitochondrial leukodystrophy or a SERF1 mutation? The mitochondrial leukodystrophies, at least imaging wise, can present with confluent white matter abnormalities, but the corpus callosum was slightly atypical in our case. There is predominant middle blade involvement in mitochondrial disorders, whereas our case had inner blade involvement. Other than that, succinate dehydrogenase deficiency can present with these predominant periventricular confluent white matter abnormalities, but there is usually a succinate peak around 2.4 on the spectroscopy, which is typically seen in most of the cases of succinate dehydrogenase deficiency. So this is an example of SDH, but the spectroscopy did not demonstrate any diagnostic peaks for that. SERF1 mutation, the brainstem and the cerebellar changes are not typical of SERF1 mutation. They involve the different regions, separate regions of the brain, predominantly the cerebral peduncles, periaqueductal regions, and also the dentate nucleus. Ours were more confluent brainstem involvement. So and usually they do not present with these confirmed white matter abnormalities. I don't think vanishing white matter fits into it because there is involvement of the brainstem, but there are a few isolated cases with vanishing white matter abnormalities presenting with these confluent changes and reversal on the T1 and FLAIR images. So at least on imaging wise, I would think that it is most likely genetic, but whether it's a nuclear DNA disorder or tRNA disorder, that needs to be ruled out, and it's not typical for SERF1 mutation. So I'll open the case for the panelists to comment on now. And it doesn't fit into HSV, as at least not typical findings of HSV.
Nothing to add, Nihaal. Genetic.
Okay. Anyone else has any further comments or suggestions?
Are you planning to repeat imaging after a few weeks or months?
No, sir. Actually, we are not, sir. The child has lots of
Financial issues?
Yeah, like we may do it, sir.
I think that would be dependent upon the gene, if I'm right. If you get a positive gene, I think.
Yes, sir.
I think okay, I don't think we have any further comments. So we'll wait for the genetic analysis and give us the feedback side.
Yes, sir.
Yeah.
Thank you.
All right, thanks. Yes, Geeta.
Yes, sir. This child is a 5-month-old female child with normal development and no perinatal issues and very well thriving child. So presented to us with just history of fever for 2 days, and post that child had right focal status and advancing into SRSC with EEG changes also, and requiring a ventilatory support almost for 4 to 5 days. And we had to give even the midazolam infusion. And later on, after the midazolam for almost 24 hours, the child responded, like the seizures have control. So initially on day 2, we have done a CT, which was showing the patchy hypodensities in the white matter region. And we have done a MRI to know the prognosis, like in such a well thriving child and all, the cause for SRSC. And investigations wise, we have done the normal routine like a CBP, CRP and all. They were normal. There were no evidence of any transaminitis and all. And we have also done the CSF.
Yeah, we'll wait for the images first. Yeah.
Yes.
So this is the MR picture, and you can appreciate there are confluent asymmetrical distribution of cytotoxic edema involving the deep predominant subcortical cortical regions of the temporal lobes, the frontal regions, some areas of the parietal lobes and occipital lobes on the left. But predominant involvement is along the temporal lobes on both sides. Confluent abnormalities with cytotoxic injury. Corpus callosum, the splenium of the corpus callosum and the isthmus also demonstrates area restricted diffusion. So predominant cytotoxic edematous changes, no structural malformations. The thalamus also is involved, the central white matter also involved, but also again in an asymmetrical pattern. The SWA sequences did not pick up any hemorrhage or calcification. Spine staining was done, which did not demonstrate any focal or long segment abnormality. Post-contrast study did not show significant enhancement. Some areas of leptomeningeal enhancement over there, but are not very significant. So based on the imaging pattern, we had suggested a possibility of HSV1 encephalitis, given the age of the child and the distribution of the abnormalities. They usually present with asymmetrical and confluent abnormalities, predominantly involving temporal lobe, but there is extension into the frontal lobes and other lobes other than the temporal lobes. They can present with hemorrhage, but usually they spare the deep gray matter, but not always. So HSV was the primary differential given. for this case, and these are the results. Geeta?
Yeah, yes, sir. Like first, initially based on CT, we thought of more of a bacterial because in that there were not much temporal changes. So in that Acinetobacter was positive. After the MRI, we have sent for the for the viral panel, and that HSP was detected. And even CSF was showing a protein of 227, like raised protein, glucose 43. And in the cell count also, it was like WBC was 280 and RBCs were 50 cells.
Okay. So the query here or the doubt or what do you want to ask the panelists?
Just the pattern of involvement.
Okay. Dr. Sangeeta, Ivan, or anyone wants to comment upon?
Yeah, the clinical picture as well as imaging are favoring more of an HSV. No, it's an acute presentation with febrile encephalopathy with status. Am I right?
Yes.
Geeta?
Yes, yes, sir.
So the dilemma was bacterial or viral. That's the only question. Right?
Yeah, initially, yeah, we were more of a bacterial, we thought, but after the MRI and all, we had a confirmatory diagnosis with the PCRs.
Okay.
Did the child recover?
No, ma'am. The child actually went on LAMA. Like seizures wise, it subsided, but required prolonged ventilatory, and they had the financial issues. Now, the child is improving.
Okay.
Dr. Surya says needs immunodeficiency workup.
Yeah, we have done the immunodeficiency workup also. It came out to be negative.
Yes, spleen of corpus callosum all viral infections common. Is it inflammatory around post-treatment? The involvement appears to be typical of HSV1. They usually affect the extratemporal and temporal regions. Possibly thalamic changes are post-victal, but the lobar involvement is typical of HSV. Okay. So we'll move on to our next case. Thanks for the case, Geeta. And question: can HSV and varicella coexist in the same child? Anyone wants to? Is that on imaging or clinical? ADEM at 4 months. I don't think so because we got the HSP on the viral PCR. So okay, so we'll move on to our next case. Sorry, Hina, if you're there.
Yes, I'm here.
Yeah.
Good evening, everybody. This is a 7-month-old child, fourth child of third-degree consanguineous marriage. She presented at 4 months. She presented to us at 4 months with excessive irritability in the form of inconsolable bouts of crying, and she had some developmental delay. Developmental delay was in the form of she did not have any neck control at 4 months. She was making momentary eye contact, but she did not have any social smile. So on examination, her head circumference was 40 centimeters, which was between 3rd to 40th percentile. She had mild facial dysmorphism in the form of large, a long philtrum, long and flat philtrum, and short stubby nose. She had enlarged bulging eyes. And on examination, she also had bilaterally restricted lateral abduction with bilateral esotropia. She had axial as well as she had complete head lag, and there was axial as well as peripheral hypotonia. Sorry, that was hypotonia, peripheral hypotonia with reflexes well elicitable. Also, on asking about the family history, she has one elder sibling who also had developmental delay. This child is now 4.5 months old, 4.5 years old, and she started walking only after 2 years. She also, the mother also says that her speech was also delayed. At present, though she is able to walk and she's also able to run, she speaks in full sentences, but her speech is not very fluent. And she goes to Anganwadi school, but she, as per the mother, actually.
Ina, just to stop you there, I have put the slide for the elder sibling after the images, so maybe you can get
Okay,
back to it
sure.
after that. Yeah.
Sure, sir.
Okay.
Yeah. So in the video, we can see that. Okay, sure, sir.
Sorry. Yeah, go ahead.
Yeah, so here we can see that there is bilateral esotropia, there is bilateral lateral abduction restriction, and there is jerk nystagmus towards the right. This is an index patient. This was 7 months.
Thank you.
Okay.
So we have the MR, the T2-weighted sequences. As you can appreciate, the predominant findings are in the posterior fossa. There is cerebellar dysplasia with cerebellar cysts. Brainstem is slightly hypoplastic. The corpus callosum is slightly thinned out over there. Supratentorially, there are no malformations, no focal lesions or signal abnormalities. Ina, at what age was the scan done?
This was done at 4 months.
Okay, so myelination is, I mean, at a 4 month, they are complete. There are areas of unmyelinated brain, which is normal. The globes are slightly enlarged, not very significant, but yeah, slightly elongated over there. Typical, I mean, the main findings are cerebellar dysplasia. The fourth ventricle again is slightly dilated, almost like a 10-shaped appearance, and some brainstem and corpus callosum hyperplasia are there. Before moving on to the discussion, this is the elder sibling. You know, if you want
Yes.
to...
Yeah, sure, sir. So this is an elder sibling. Now she's 4.5 years. As I told earlier, she had delay in attaining milestones, but she can walk, she can run now, she can climb steps. She speaks in full sentences, but her speech is not very fluent. And she goes to Anganwadi school, but her mother says that she has difficulty learning new things, and intellectually she is not at par with other children of her age group. Though we haven't done a formal IQ assessment yet. On examination, she also is found to have bilateral esotropia with limited, with restricted abduction in both the eyes. She has hypotonia. Her reflexes are normal, and she the gait is like broad-based gait, just as we are seeing in the video. Broad-based gait, and she is having some non-progressive ataxia.
Okay.
Yeah.
So these are selected images of the sibling, and the imaging phenotype is pretty similar to the index side. Again, cerebellar dysplasia is abnormal, almost 10-shaped or square-shaped fourth ventricle. Again, brainstem and corpus callosum hypoplasia. No supratentorial structural malformations. Again, the globes are slightly elongated, but not significant. Given the imaging findings and the clinical findings, possibility, I mean, I think there are no other considerations. Paediatric syndrome would be considered. The typical imaging findings which are seen in both the patients are the cerebellar cyst, the cerebellar dysplasia, the fourth ventricular enlargement, and this typical 10-shape or square-shaped fourth ventricle. They usually do not have supratentorial malformations, and the clinical findings which are seen over here are also present in our case. These are just differentials for cerebellar cyst. On imaging, they can have cerebellar cyst, but the congenital muscular dystrophy has a dysplastic or dysmorphic brainstem, and they usually have supratentorial malformations. The ADGRG1 also has cobblestone malformations in the supratentorial brain, which is not seen in the Paediatric syndrome. Again, few differentials for cerebellar dysplasia. Again, in our case, they usually have eye changes with multiple cysts. So LAMA1 mutation is the prime differential to be considered, and these are the differentials for the patients presenting with cerebellar dysplasia. We have Dr. Bolthauser, who the syndrome is named after, so maybe he can give us few pointers towards the diagnosis. Genetics wasn't done for this time.
Yes, so genetics was not done. So based on the MRI, CPK was done, which came normal, and ophthalmology consultation was done. And both of these siblings are found to have high myopia, though there is no retinal degeneration as such. They have refused for genetics for the time being, but so they might agree later on. I'm not sure, sir.
The question is, do we need genetics?
Yes, sir. That is one question. So,
Yeah.
so it's like all the clinical signs and symptoms and the MRI, they're so much suggestive. So should we go ahead with the genetics, or we can just based on this, we can prognosticate?
Yeah.
I think the overall context in terms of history, clinical finding, the MR in two siblings are very suggestive of LAMA 1. There is hardly any differential diagnosis I can think of. There can be mild forms of congenital muscular dystrophy. I've seen sibling pairs, they had similar MR, and but they had proximal weakness and the CK in the thousands, and they had a mild form due to ISPD gene muscular dystrophy. But here, I think LAMA 1 is top on the list. And these patients usually have high myopia, not all, very often. They have congenital oculomotor apraxia. This, by the way, tends to persist into adult life, in contrast to other forms. They have variable cognitive impairment or can be cognitively absolutely normal. And dysmorphic signs are not really known to me. Yeah.
So another question is that this retinal dystrophy, can it develop along the course of the disease, or since it is not there now, do we have to monitor it?
Retinal dystrophy?
Yes, sir.
Yes, this can still be evolving.
So we'll have to keep monitoring for that. We have to keep looking for it, isn't it?
I think she needs a careful ophthalmological follow-up and of course clinical follow-up.
Okay, sir. So regarding the genetics, should we go ahead with the genetics if they're willing, or so since it is very since it is very suggestive?
I mean, it's always nice to have genetic confirmation, but it would be very unusual to find something else or find nothing.
Sure, sir. Thank you, sir. Thank you so much.
Thank you for sharing this case.
You're welcome, sir.
Thank you again. Thank you, Ina.
Thank you, sir.
To our next case, Subi, there.
Yes, sir. Good evening, everyone. So this was a 5-month-old child, came with the complaints of developmental delay. The child had motor more than cognitive delay. At 5 months, she was cooing. She was smiling more to the auditory stimuli, and she was responding well, but she had no neck control and no rollover. Examination wise, she had dysmorphism in terms of microcephaly. She had microphthalmia as well as cataract, and the pupils were also slightly smaller in size, like almost myotic, but the cataract was still visible. And other than that, there were no pyramidal signs or any other findings on the CNS examination. Birth-wise, there was a history of late preterm birth, and the child was low birth weight, so kept in ICU for probably the low birth weight and some respiratory distress, but no major issues. The maternal history was also insignificant for this child, but the child has a significant family history. So this was a 5th born child, and prior to this, 2 siblings probably of the same facial features. The mother was not sure of the facial features exactly, but both the children had cataract in both the eyes, and they also had significant developmental delay. Both of the children started developing seizures at around 1.5 years of age, and they succumbed at 2 years and 19 months respectively. Both of them were males. And then there were 2 abortions in between, and there was a 3rd child. She's a 7-year-old healthy female child, and then this was the 4th born. So considering the similar facial features and the phenotype in the siblings, and with this child, we were thinking of something autosomal recessive, though there was no consanguinity in the family. And then we asked for the MRI. The MRI was already done at 3 months of age. So we can discuss the MRI and then our thoughts about it.
So we just for the radiologist, can you describe the findings of the child?
So there was a microcephaly and a microphthalmia. The eyes are slightly smaller. They may not be so much appreciable in the photograph, but they were small. And there were bilateral epicanthal folds, and there was cataract in both the eyes, and pupils were small in size, like almost 1 to 2 mm pupils.
Okay. And any facial dysmorphism? I mean, nose, chin.
So apart from that, a slightly depressed nasal bridge and slightly prominent philtrum in upper thin upper lip. But yeah, those were the facial features. Other than that, nothing. So just based on the facial features, one differential was Warburg micro syndrome. But there was no hypogonadism in this child. The previous siblings, I'm not sure if there was any.
We'll move on to the imaging.
Yes, sir.
So we have Geeta doing a PMG study. So I'll let Geeta describe the findings if he's there.
Yes, sir. So in the T2, like there is a polymicrogyria, it is there, which is mostly the frontal dominant, and also the white matter appears normal, and even the basal ganglia complex is normal. There is no dysplastic or dysmorphic. Ventricles also, like only the occipital horns appears dysplastic, and corpus callosum is thinned out, sir. And there is a mild Vermean hypoplasia, it is present. And there are no temporal lobe cyst or no periventricular cyst in this.
The orbits are slightly small, microphthalma. And scan at 3 months is slight delay in myelination of the anterior limb of the capsule. It should be visualized at 3 months. So other than that, predominant frontal polymicrogyria, some areas of dyschargia along the occipital lobes over there. The white matter hyperintensity is a 3-month-old child, so that's an unmyelinated brain. Yes, mild thinning of the corpus callosum, microphthalmia, frontal polymicrogyria, and some degree of vermis hypoplasia. So Warburg micro syndrome was the clinical possibility. We'll get back to the images after the imaging findings. So the main imaging findings for Warburg micro syndrome are they usually present with predominant frontal polymicrogyria, as demonstrated in these examples. They can have corpus callosum hypoplasia, cerebellar hypoplasia, increased subarachnoid spaces, and enlarged acroventricles. So some of the features that fit at least the imaging phenotype of the Warburg micro syndrome. The other genes which can present in predominant frontal polymicrogyria are these, out of which again the Warburg micro syndrome gene is present. So the imaging differentials are these, but some variations are there on the clinical phenotypes. At this point, I'll open the case for discussion.
Someone asked regarding the CPK. The CPK was not done for this child, sir.
Just on the panel over here, does it match with the pictures from literature? I think they demonstrate low set ears, depressed and wide nasal bridge, small eyes, thin lips, as seen in our case.
And
Question
the
is it
cataract and atonic pupil was also like mentioned in the. For this child, there was no history of seizures, but the siblings had seizures after 1 year of age. 2 siblings with similar facial features had seizures.
Someone has mentioned, Dr. Shiji has mentioned that the facial features match the public literature. In the imaging finding also predominant frontal polymicrogyria, corpus callosum changes, and some posterior fossa changes are seen to be described in the syndrome. So I would say it's a good match on the imaging at least. Anything to add, Ivan or Dr. Sangeeta or anyone else on the clinical phenotype?
I haven't seen a patient of myself, Walker micro syndrome. So,
okay. So, are we getting genetics or not affordable?
I'll maybe ask them, but I think they're not planning for any further pregnancies.
Yes. Okay, so at least on the discussion, the imaging and the facial features have a good match. So a possible diagnosis, I would think.
Thank you. Thank you, everyone.
Okay, thank you. Next case is from Belgaum. Ashwin, if you're there. Or Dr. Kamble.
Yes.
Yeah.
This is a 1 year, 6-month-old female child, non-consanguineous marriage. Came with now the history is now the child is having illness for almost 2 months now. So about 1.5 to 2 months back, child had 4 episodes of seizures. So that the history was such that the child was having initially fever, which was on the day of 2 weeks duration. And on day 8 of fever, child developed right versive seizures with right clonic upper limb and lower limb movements, followed by vomiting, and seizures lasted for almost half an hour. At that time, the child was in altered sensorium for 3 days. And the CSF done at that admission was showing a protein of 15 with sugars of 58 and cells were 7, which were all lymphocytes. At that time in that hospital, the IgM for HSV 1 and 2 were done, which were negative. Thereafter, this child was fine, was discharged and was active with normal behavior. But 1 week later, the child again developed fever and had a second episode of seizure, which was similar in semiology, that is right clonic, and it lasted for 10 minutes. Child was readmitted, and that time child was put on IV antibiotics, acyclovir, and dexamethasone was given. Towards the 3rd week of the illness, child developed left side versive seizures, left clonic seizures, and this time which lasted for about over an hour. And then the child was in altered sensorium for next 3 to 4 days. And since then, the child has been irritable, has had abnormal movements in the form of dystonia, chorioathetosis, and oromotor dyskinesias. And the at about the 25th day of this, since the start of the first fever, this child's CSF was done. That time the CSF was showing proteins of 81, sugars of 47, and CSF cells which were 720 with 70% neutrophils and 30% lymphocytes. And the ferritin that time was 32, the procalcitonin was 0.08, homocysteine 9.6, ANA was negative. And at this time, the child was started on anti-tuberculosis drugs, considering the high CSF cells and protein of 81. But then the child was non-improving and with having abnormal movements persisting, child was referred with a suspicion of autoimmune encephalitis. When the child was received by us here with a clinical suspicion of autoimmune encephalitis, child was given pulse methyl prednisolone for 5 days. And at that time, the child was also continued on anti-seizure medications. Child had persistent severe dyskinesias, and for which the child was successively put on clonazepam, risperidone, clonidine, tetrabenazine, chlorpromazine. Also, IV midazolam infusion was given up to 10 microgram per kg per minute for 5 days. Even put on ketamine. However, the abnormal movements have been still persisting. And child also has insomnia and also has a lot of bruxism. Child hardly sleeps because of these abnormal movements. A CSF done on 19th November, that is at about almost
Ashwin, I'll just stop you there.
Yeah.
Let's go in a sequential manner. Can you describe the findings of the video?
Yeah, so this child is having a severe, has dystonia with little bit of arching of the back, also has abnormal movements, chorioathetoid movements, oromotor dyskinesias, and these are very much persistent. And this is a very recent video now, and even till date. So the illness has started somewhere at about the last week of September, and presented to the previous hospital in the month of like towards the last 30th of September, and throughout October was in another hospital, admitted to us on 1st of November. And now today, 25th November, this child continues to have these kind of abnormal movements, which despite all the drug medications is not improving.
Okay, we'll have a look at the images first. So these are the initial images done outside, slightly extracted images over there in September. There is some supratentorial reduction in the frontoparietal regions and the superficial lobes over there. TPA structures cannot appreciate any focal lesions. Brainstem and cerebellum, again, no significant abnormalities. Flare cannot appreciate any edematous or hyperintense changes. This is artifactual, this focal hyperintensity. But other than some degree of cerebral atrophy, there are no clear markers for any possible diagnosis.
This is
So
at the
follow-up
first
scan.
episode.
Okay, yeah. So follow-up scan in October 14, that is 2 weeks later. There is a mild progression of the cerebral atrophy, but you can appreciate now that there are abnormalities in the left subcortical cortical region of the parietal, temporal and occipital regions, predominantly in the subcortical and cortical regions. So hyperintensities on the left side. On the FLAIR images, you can appreciate some areas of abnormality also involving the frontal white matter, the contralateral parietal lobe, over there the periventricular white matter, the pulvinar thalamic nuclei on the left, and again the corresponding findings of the left temporal and occipital regions, predominantly known as subcortical and cortical regions over there. Basal ganglia demonstrate no signal abnormalities at this stage. Follow-up scan on the 19th, that is 5 days later. Again, some degree of volume loss with these persistent subcortical cortical changes, predominantly involving the parietal, temporal, and occipital regions on the left. Thalamus again is involved, the frontal white matter, some patchy areas over there, and the right parietal white matter. Diffusion weighted sequences, there was again a slight area of restricted diffusion on the contralateral right pulvinar thalamic nuclei. But other than that, these lesions do not demonstrate any restricted diffusion. So this is the follow-up a week later, and you can see that the imaging findings have significantly progressed, now more confluent, involving the bilateral cerebral white matter of the parietal cerebral hemispheres, also involving the periventricular and deep white matter, which was not seen previously. The left temporal parietal occipital region now demonstrates this area of cystic degeneration over there, some gliosis and volume loss, corpus callosum slightly thin, but yeah, so in a week's time, there is significant progression. So before going to the discussion, I think the antibodies were tested. Ashwin, do you want to?
Yes. So the repeat CSF, which was done on 19th November, it was showing just 5 cells, which are lymphocytes. And the serum was tested for MOG antibodies, which were negative. CSF for GABA-A, GFAP antibodies were negative. However, for anti-NMDR, it came moderately positive. Child has received 2 doses of rituximab 1 week apart. Thereafter, even IVIG was given. Child has been continued on oral methylprednisolone. However, as you see in the video, that is the current status of the child after this long period of illness, and despite multiple medications for the abnormal movements. So there are 2 queries now. One is that whether this is an atypical MRI finding for NMDR, and secondly, from a clinical perspective, as to whether any other line of treatment can be considered in view of this child's current condition.
Okay. Was the CSF PCR done?
PCR for HSV was not done. The initial admission outside, only they had done IgM for HSV, which was negative, but PCR has not been done.
Okay. Yeah, as someone pointed out, demyelination is one of the possibilities, MOG antibody, but we have a negative MOG. These are some confluent abnormalities involving the NMDR, possibly post-infective. As you can see, they progressed to these areas of cystic degeneration, but this scan was over 6 months of time in comparison to the initial scan. Also was thought of a recent scan which we had seen, which developed cystic degeneration in the follow-up period, but that was the case of an SSPE. This child, I don't think, has typical EEG features, or the measles antibody was tested, but that was a differential, at least on the imaging findings. So post-infection causing NMDR encephalitis, an atypical variant, is a possibility. Other immune deficient disorders to be considered. So at least on the imaging wise, that is what we're thinking. I'll open the case for others to comment upon now, clinical and imaging point of view.
Have you done HSV PCR? It was negative on CSF?
No, ma'am, it has not been done. because the patient has presented to us almost after 5 weeks of the start of the illness, and then we got a test positive for NMDR. So child was being continued to be managed for that, but a PCR has not been done yet.
Post-HSV and MDR encephalitis is still a possibility. You can even test a serum if you have a PAT sample. You can test the HSV IgM antibody in case if you're not able to test the PCR because the samples are leftover samples are there.
Yes, ma'am. Yes, ma'am. IgM was done for this child outside before the child was referred to us. At that time, it was negative, but perhaps it was too early in the illness.
The other differential, could it be MELAS?
Toe-like symptoms, Ashwin?
Pardon me, sir.
The question was the child has stroke-like symptoms for MELAS.
No, there have been no neurological deficits as such. Mainly, the child is having child was initially encephalopathic. Thereafter, child has been irritable with abnormal movements, dystonia and dyskinesias, choreoarthroid movements. That is what has persisted for this long.
CSF lactate, blood lactate, MRS, any lactate peaks?
I don't think MRS is available.
Not done, ma'am.
Not done. Yeah.
So considering it as you are considering it as a refractory anti-NMDR encephalitis?
Yes, ma'am.
So are you planning for intensification of the immunomodulation considering tocilizumab? Tumor surveillance was negative?
The abdominal ultrasound was done to look for a tumor that was negative.
Okay. Maybe you can try tocilizumab.
Okay, ma'am.
Dr. Kamte, anything to add regarding the child?
I just want to know that based on the second MRI, where the child had this lesion in the left posterior region, what can be the possibility? Can it be some infective cause which triggered NMDR antibodies, or this is the third one, the second MRI?
This one, right?
Yeah, this one. This is not typical for herpes, no? Not very typical for herpes, I think.
But at this age, maybe, not typical, really bilateral, but there were some areas of bilateral involvement. But yeah, I would still think herpes would have been a possibility. Slightly atypical, but yes.
Okay.
The CSF also, I think, was suggestive of an encephalitis type picture.
Yeah, 720 cells were there. Yeah. I think we'll do a HSV IgM now, IgM and IgG. If it turns positive, then we can suggest herpetic illness. Yeah. But the abdominal movements are quite typical for NMDR. And despite all the 3 first-line therapy, the child continues to have movement. I think as Sangeeta suggested, we can try tocilizumab now. We'll give a trial. Yeah. Thank you.
Thank you. To our last case, Jayant, if you're there.
Thank you.
Yes, I'm presenting a case of 8-year-old boy who had history of fever since 3 days and altered sensorium since 1 day. A child also had diminution of vision since the last 1 day, which progressed very rapidly over the next 24 hours to complete vision loss. And this child had no prior significant history, perinatal development, past history, and family history was normal. On examination, the child was conscious but irritable. The GCS was fine, 14/15. The visual acuity, there was only light perception. And the pupils were bilaterally reactive but sluggish with a normal fundus. And other cranial nerve examinations and rest of the neurological examination was normal, except for exaggerated deep tendon reflexes and extensive plantars. And on coming to the images, we had.
So we have an outside MR, again, not very clear images, but on the flare on top, you have these edema or hyperintense stages along the optic pathway, the optic nerves, the optic tracts, and also the optic chiasm, the optic tracts, the predominantly optic pathway involvement demonstrating flare hyperintense stages. And on the post contrast, you have some perineuritis like picture of the optic chiasm and the proximal optic nerves. Other than that, I cannot appreciate any leptomeningeal or or any meningeal enhancement, no focal lesions. But again, this quality of image is not ideal. So yeah.
So following this, we had repeated the imaging when the patient came here. So the following pictures, the imaging.
What is the interval period?
Sir, it was after 1 week, so the patient came here.
Okay.
So we repeated our imaging here. So we had, sir.
So no neurocutaneous markers, no?
No, sir.
Okay. So again, on the repeat images, you have focal hyperintensity in the right frontal lobe over there. The plicks demonstrate these hyperintense changes. Along the optic pathway, we have these hyperintense areas also involving the optic chiasm, the tracts. Similar changes on the T2-A2 sequences, some degree of mild reduction in volume, but nothing significant. No focal lesions, no malformations. We zoomed in images of the T2 and the player images. Again, you can appreciate bulky optic nerves, optic chiasms. I think the coronal and the sags don't add much to the abnormalities. Post-contrast, there is some degree of enhancement of the bilateral optic nerves. I don't have post-contrast images lower down. Only the optic nerve images are available. Again, the player images over there demonstrating these hyperintense changes with post-contrast enhancement. No spectroscopy wasn't done.
No, sir.
Right. So after that, I think this is the follow-up.
So considering this fundus was normal, the retroorbital optic neuritis was considered. So we did CSF. CSF showed around 180 cells. Protein was near normal, 43, and glucose was normal with simultaneous blood glucose of 92. And ADA was 1.3, which was normal, and VP showed bilateral absent response. And we wanted to rule out MOGAD, so serum MOG was done along with aquaporin 4 antibodies, which came back negative. And infective workup, CBC, dengue serology, Vidal, and COVID antibodies were also negative. So we also had considered COX in view of high cells and some amount of basal exudates. So we thought of TB workup as well. Monto, sputum, CSF for AFB, CBNAT of CSF, everything came back negative. So at this point, we had a doubt whether it could be infectious or demyelinating more. However, we treated for both of it.
Yeah. And after that, we have a set of images.
Yes, sir. So we have given a trial of methylprednisolone, high dose pulse methylprednisolone for 5 days. And following that, the response was not adequate. So we went ahead with IVIG. So after IVIG was initiated, the child had hypertensive readings and new onset seizures. So we repeated our imaging. So we had changes of stress as well. So coming back to the first, whether the optic neuritis was demyelinating or infectious. So do we further go with any other investigations? So how do we proceed? So currently after this methylprednisolone IVIG, currently the child is at 4th week of investigations, and the child has finger counting now. So there's only a partial response. So do we do any more investigations currently? We have done CSF oligoclonal bands, which came back negative, and the CSF viral panel we couldn't send, but Epstein-Barr virus serology was done, which is awaited.
Okay. I don't have non-contrast images, but the contrast images are, you have this cortical and leptomeningeal enhancement along the posterior cerebral hemispheres on both sides, some degree of enhancement again along the optic pathway. These are almost typical of breast-related changes or vasculitis type pattern. Again, these are just examples from literature demonstrating similar imaging findings. MRI spine is the question. Spine was normal. Sorry. So, oops, I'm sorry. Yes. Going back to the initial images, if you see the follow-up, there are some areas of extra optic pathway involvement. So some focal patchy areas in the right frontal lobe, also in the temporal lobe over there. I would think of demyelination first, the possibility, then infection. Optic pathway glioma was sort of, but the enhancement pattern doesn't match it, and there are no neurocutaneous markers, and the optic nerves are not as bulky as what would one see in an NF1 patient. And this predominant optic nerve involvement rather than the pre-optic nerve involvement. So those are the differentials on imaging. but the antibodies I think have come out negative. Am I right then?
Yes, sir. Yes,
All
sir.
that.
So do we further go ahead and do ANA and other autoimmune workup in this? Do we have to go in that line? And do we have to consider treatment for COX, even though the treatment, the workup was negative? We had that doubt. So.
Yeah. I'll open the question for the clinicians if they want to answer that. Dr. Sangeeta or Aiden. CSF antibody, anti-MOG antibodies was the suggestion to be sent. Hypertrophic pachymeningitis, there is no pachymeningitis, there is vector-meningeal enhancement. So,
have you done an ACE level for a neurosarcoid workup?
No, ma'am.
So I think you can do an ACE level, serum calcium, urine spot calcium, creatinine.
All right, ma'am. Ma'am, any do we empirically start ATT in this patient considering high cells?
Did we do a cytospan with that cell count of
yes,
CSF cell? 180 cells. Was there any abnormal cells? Anything to suggest of any CNS lymphomas?
No, ma'am. We just had that automated.
Flow cytometry was done.
No, ma'am. No, ma'am.
I think as of now, do we have any strong evidence for tuberculosis?
No,
I don't think so.
Yeah.
No, I don't think there's basal enhancement. I mean, there's internal enhancement also, at least on the initial images. So, I mean, they can present the optic neuritis, but the basal systems are relatively clear. Could it be a seronegative demyelination? That's a possibility. Does it match clinically? Okay, there's a suggestion of post-infectious immune mediated encephalitis anti-MOG. Further testing for MOG.
MOG has been actually already done in serum, which is more sensitive. Okay. So the initial scan, which is done outside, reported as basal enhancement. That's what confused us, and the clarity was not clear. When we repeated, and that was not seen, as you correctly said. And protein was also normal in CSF. Yeah.
I think there was, I mean, TB is not a strong handle, at least.
Yeah, okay. We'll get the autoimmune workup done, like ma'am said, the sarcoidosis workup as well.
Yeah. Okay.
Thank you so much.
Thank you. And that's our last case. So once again, thank you, everyone. We'll meet again on the 9th December. Kindly send your cases by 6th December so that we can send the cases to our panelists, and we'll see you again on the 9th. I'll thank again once again, and Dr. Sangeeta for joining us.
Thank you, everyone.
Thank you, and thank you everyone in the chat also for helping out with your suggestions. Thanks a lot. Bye-bye.
Thank you.